Good day to you, dear colleagues. This is Professor Yaser Natour from the Department of Hearing and Speech Sciences and Disorders, School of Rehabilitation Sciences, University of Jordan. My presentation today would tackle dysphagia in patients with Down syndrome. I have worked extensively with dysphagia and voice disorders, resonance disorders, and so on. I did receive some patients with Down syndrome, even those who are neonatals. So I hope that you enjoy the presentation, and I hope to discuss the related issues in the Q&A section. In my clinical practice as a professional with expertise in dysphagia, voice disorders, resonance disorders, and neurogenic disorders, I've always received patients that have developmental disabilities, including Down syndrome and autism spectrum disorders, cerebral palsy, and so on. As a clinician and a researcher, I've always read research regarding developmental disorders and wondered why would people not really put a lot of focus on dysphagia in those children, especially in Down syndrome. Studies are showing that 80 or to 90% of the population of children and adults with developmental disabilities have dysphagia, but we really do not provide the proper service for those. Research and clinical practice show that children with Down syndrome do have certain anatomical and physiological problems, and those problems would interfere with the ordinary oral motor skills necessary for regular feeding, which leads to problems in swallowing and eventually problems in nutrition. Those swallowing problems would affect the oral and oral preparatory phase of swallowing, chewing, and preparing the bolus, and also in the pharyngeal stages of swallowing. Nearly as studies show that around 50% of those children would have poor bolus control and manipulation and difficulty in swallowing large boluses and difficulty in chewing. For example, children with Down syndrome would have poor lip seal, food loss, and some weak tongue lateralization skills. Interestingly enough, studies shows that 60% of children with Down syndrome may have oral facial difficulties, weak lip closure, tongue thrusting, and chewing difficulties. 20% of them have oral sensory problems also. As for the pharyngeal stage, they are also suffering from swallowing problems. Even when explored with video fluoroscopic studies, there are more than 50% of those children have pharyngeal stage dysphagia with possible aspiration. It's really surprising that 90% of children with Down syndrome who had aspiration had it silently, so no cough or clinical symptoms. They would have pharyngeal residue, delayed swallow initiation, upper esophageal sphincter dysfunction, or sometimes they are reported to have even esophageal problems in the esophageal phase of swallowing. Another problem that those children with Down syndrome may suffer from is gastroesophageal reflux disease, GERD, which causes irritation in the throat and may cause food and feeding refusal. As for specific problems that children with Down syndrome may suffer from, they are listed below, but the most interesting is that they have some delay in triggering the pharyngeal swallow. We might not know that, but it is there. We need to check their lip seal, their poor lip seal, the effect of the large tongue, and other problems. So they do, as other children, suffer from some sort of dysphagia. There's the rest of the list that contains reduced laryngeal elevation, reduced tongue-based motion, and sometimes bilateral pharyngeal or unilateral pharyngeal wall paresis, and this may lead to aspiration, and aspiration may lead to pneumonia. Pharyngeal problems in children with Down syndrome may be suspected when we hear a wet, gurgly voice quality, or when the child shows no interest in oral motor activities that involve food. So what to do? What are the management strategies? Some of the management strategies are postural changes, sensory input changes prior to the attempt to swallow, volume, taste, active exercise, oromotor therapy. Those are traditional therapy that every speech language pathologist knows about. The non-traditional management strategy is neuromuscular electrical stimulation, a new way of treating dysphagia in Down syndrome, children with Down syndrome, and other children, in fact, is neuromuscular electrical stimulation. Speech language pathologists have always used a number of techniques to improve swallowing in the traditional sense of training, where we would use larger volumes of boluses, change the viscosity, and presenting strongly flavored boluses. And sometimes we use sensory motor exercises, as you see in this display, even stimulating the lips and the tongue using the fingers, sometimes using a toothbrush or a piece of a cloth. Sometimes some stretching exercises might be helpful in improving sensory stimulation. Again, a simple piece of cloth, using sometimes thermal stimulation with ice and other lemon and ice and so on to stimulate the swallowing in a better way. Stretching exercises again for the lips and the cheeks, using some tools to stimulate the lips and the tongue, using thermal stimulation and massaging the genohyoid and mylohyoid muscles at the floor of the mouth. Again, using a straw and thermal stimulation using ice. Sometimes some quick stretch using the fingers on the lips. Sometimes even tapping the lips to increase the awareness, the sensory awareness that food is coming now. Please be prepared. Again, using a tongue depressor, desensitizing the tongue. Sometimes those children with Down syndrome may have hypersensitivity, hyperactive gag, and so on. Straw would really teach a good lip seal, so we would use it also. Again, lip seal. The whole idea of neuromuscular electrical stimulation, NEMS, is to send or use electrical impulses to the nerves and muscles to contract and to re-educate the muscles and increase the strength and range of motion that were had some effects of disuse or some sort of hypotonicity and to regain the strength of the muscles, in fact. Neuromuscular electrical stimulation is a rehabilitative therapy. It's non-invasive, it's approved, and has a good body of research tackling this area. I myself, as a clinician, did use it even in neonatals. children with Down syndrome who are still infants. Listed below are some instruments that are commercially available for those who need to use electrical stimulation with patients with Down syndrome. Here's what the instruments, neuromuscular electrical stimulation instruments look like. All the instruments of neuromuscular electrical stimulation work on one principle, that is depolarization or creating action potential. They create an electrical current, they cause the movement of electrons, and they transfer them through the skin to the muscles, the concerned swallowing muscles. There are stimulation levels for these stimulation levels. The first is subsensory level, where the patient feels some sort of a numb, a subtle electrical sensation. Then the sensory level, where the sensory nerves are stimulated, something like pins and needles. And then the motor level, where muscles start to contract without causing pain, and this is the level of muscle education. The level that we do not want to reach is the noxious level, where it might cause some pain, so we do not want to go there. Some resources recommend 3 to 5 times a week with duration of stimulation for 1 hour, but I recommend combining the stimulation, electric stimulation, with active exercises, in fact. Now, who is in charge for NMS, or neuromuscular electrical stimulation? A certified speech therapist, occupational therapist, or MD with a certificate of service provider. I got mine, and I am a service provider, but people are encouraged to do it and obtain the service provider certificate. Then when we apply the electrical current, it's really non-invasive, it's mainly non-expensive, not expensive, but you need more amplitude to reach deeper muscles, in fact. We use it as speech-language pathologists to relax muscle spasms, to prevent atrophy, to increase the range of motion of muscles, to strengthen the muscles, and to improve local blood circulation and facilitate the re-education of muscles. Candidates are people with dysphagia, stroke, or deconditioning as a result of age or comorbidity. I did use that with children with Down syndrome with great success, in fact. Other candidates are head and neck cancer, voice disorders, which is in its baby steps yet, but it can be used for strengthening and re-educating muscles in a lot of patients. The question is, does it work for pediatrics? Yes, it does work for pediatrics. Children of all ages, cerebral palsy, children with Down syndrome, a lot of children, TBI, and I've used it on multiple pediatric cases. Counterindications are not that serious, but you cannot use it with individuals with motor neuron death or progressive fatigue, or people who might suffer skin breakdown. Cancer is a no also, and we do not place the electrodes over the carotid sinuses or use it with pregnant women. As was said, it might cause some skin irritation. Some resources reported epilepsy. You cannot use it with people who undergone recent surgery or cancer, or individuals with pacemakers or metal implants. So let's talk about specifically using NMS with children with Down syndrome. The most important is to involve caregivers and parents to be actively involved with the therapy procedures. And it is noted that most children tolerate this kind of therapy with little difficulty, in fact. Um, the most effective placement of the electrodes for therapy are as such: in front of the patient's neck, on the cheeks. Sometimes we test it pre and post using a modified barium swallow study and an extensive bedside swallow evaluation. Here's where we put the electrodes, even for children. Another figure that shows where to put the electrodes. We cannot usually place the electrodes in front of the neck, on the front of the neck, for pain management, or directly on the vocal folds to prevent laryngospasms. Last but not least is the considerations for clinicians in using neuromuscular electrical stimulation. We need as clinicians to ask ourselves, does the client meet the indications for the application of electrical stimulation device? Do we have a condition that might counterindicate the use of electrical stimulation? Does the client have a condition that would make us take precautions before using electrical stimulation? Or is there anything in the history that would counterindicate or implies the huge benefit from electrical stimulation? That's all for my presentation. I hope that you enjoyed it, and I'll wait for your questions and discussions in the Q&A period. Thank you.